we're going to get started. So thank you all for coming today. I am Tiffany Spahn, and I'm a medical oncologist at Diablo Valley Oncology, and I know so many of you in here, which is really nice. We are all here on a beautiful October morning in Breast Cancer Awareness Month because we have something in common, and that is that breast cancer has touched everybody in this room in some way. And so the majority of us in this room are women, and maybe some men, who have had or who have breast cancer and are either going through their treatments or about to start their treatments or have recently finished treatments or who finished a long time ago. And you guys are part of 3.5 million breast cancer survivors in the United States. And when I started doing this program 8 years ago now, that number was about 2.1 million. So in less than a decade, we have more than 1 million more survivors in this country. So we're doing something right. So congratulations for that. We also have in this room those of us who love someone who's had breast cancer, and we're involved in their care. We walk with them on their journeys. And then there are those of us in the room who are involved in the treatment of breast cancer. So we're all here united by the same cause. So before we get started, I wanted to just take a minute to talk about where the title of this program comes from. So this is called The Many Faces of Breast Cancer. And this program came to me about 8 years ago from AstraZeneca. And they are our corporate, or our pharmaceutical sponsors this morning. And someone I worked with at AstraZeneca approached me and said there's this national program that they've been doing around the country called The Many Faces of Breast Cancer. Would I like to bring it locally to Walnut Creek? And so we got involved and did our first panel, and we had an amazing turnout, and it was fantastic, and we had great feedback. And we did it again with them the following year. And then after that, AstraZeneca decided at a corporate level not to do that program anymore, but they allowed us to keep that title. And so Diablo Valley Oncology has continued to do this program, so now we're in our 8th year. But I did want to give a special thank you to AstraZeneca for helping us start this in the first place. When a woman gets a diagnosis of breast cancer, she is starting a journey. And this journey, for some women, is longer and more complicated than for other women. But they face this journey not alone. So they face it with their loved ones, their friends and family, and they face it with a team. And this team can often be a very large team. The team can have medical oncologists, surgeons, radiation oncologists, gynecologists, primary care physicians, acupuncturists, genetic counselors, radiologists, pathologists, physical therapists, lymphedema therapists. The list just goes on and on. So there's a very large team of people involved in helping a woman on her breast cancer journey. Another very important part of the team are organizations like the Cancer Support Community and the American Cancer Society, and we're going to hear more about them this morning. We at Diablo Valley Oncology partner very closely with these organizations and could not deliver the level of care that we do without the amazing supportive care services that these organizations provide for our patients. So we will hear more about that today. So I just talked to you for a few minutes about my panelists, and I will give you more of an introduction when it's each of their turn to speak. But I'm going to give you a brief overview on some updates in breast cancer. Christine Chung is a radiation oncologist, and she will be talking about radiation treatment for breast cancer. Sitting in the middle there, this is not necessarily in order, but is Allie Jacobs. She's one of my patients, and she's a breast cancer survivor, and she's going to share her journey. Allison Ryan is a physician's assistant and a registered dietitian, and so she'll be talking about oncology nutrition. And at the end is Dr. Timothy Leach. He's an obstetrician gynecologist in Walnut Creek, and he's got a lot of good stuff to talk about. So that's our panel. And I also want to just give a special thank you to Sandy Goldberg and Shayna Jung, who are our organizers, wherever they're hiding, and they do all of the legwork and the hard work that brings this together. So thank you to Sandy and Shayna. And so I'm going to start now. Oh, I have to tell you, first of all, turn off your cell phones, please, if you haven't already. And the way the program works is each speaker is going to give their talk. We ask that you hold your questions. And if you think of questions during the talks, write them down. You should have received some question cards in your welcome packet. And at the end of each speaker's talk, there will be runners collecting the question cards. And then after all the speakers have spoken, we will have a question and answer session where the panelists will be able to address some of the questions on the cards. Okay. So first, I would like to welcome Margaret Stauffer. Margaret is the Chief Mission Officer for the Cancer Support Community.
Thank you, Dr. Spahn. I want to welcome everybody this morning. I also see a lot of familiar faces here. And for those of you who are aware of Cancer Support Community, you can just relax and kick back. But I want to let folks who are not familiar with our organization know about some of the services that are available to you at no cost. Our services provide support, education, and hope for people affected by any type of cancer and for caregivers. And we provide specifically for breast cancer a newly diagnosed series that we do 4 times a year. We also have a monthly breast cancer networking group, and we also have counseling or home visits for women who are dealing with metastatic breast cancer. In addition to those programs of psychosocial support, we also have educational workshops on topics that are of interest to people affected by cancer, things like cooking demonstrations when you're trying to eat more healthfully as part of your recovery. We also have programs for families affected by cancer. So if you have school-aged children, we have a program called Kids Circle and Teen Talk, and that's for families who are dealing with cancer on top of child rearing. In addition to all of those programs, we also have healthy lifestyle classes. So we've got some sort of movement program or mind-body program 2 or 3 times a day during the week and also on the weekends. So we really encourage you to come and access the free services and hope that they support you wherever you are with dealing with breast cancer. Thank you.
Thank you, Margaret. And now I'd like to introduce Julianne Lee. She is a Health Systems Manager with the American Cancer Society.
Good morning, everyone. I want to start off by thanking Dr. Spahn and her team at Diablo Valley Oncology for providing this vital community event on an annual basis, which we at the American Cancer Society are very pleased to support. My name is Julianne Lee, and I'm a Health Systems Manager at the American Cancer Society. I work out of the East Bay Field Office here in Walnut Creek. We are located on North California Boulevard, just 2 blocks north of BART. I want to start off by mentioning that the American Cancer Society is the largest funder of cancer research, second only to the federal government. Additionally, we provide funds, the Society funds programs and services that are available to patients and their families free of charge. For instance, we have a call center based in Texas, 1-800-227-2345, or also known as 1-800-ACS-2345. Know that this number is available 24/7 and is staffed by highly trained cancer specialists, typically social workers who are bilingual Spanish-English, and callers who speak other languages may also be assisted via a translation line. We really see this service as a way of assisting individuals so that we can do the prep work with them so as to maximize their time at their next appointment. They're not asking their medical team basic questions such as, help me understand my blood work. These are the kinds of questions that our specialists can address. So remember to know that, just be aware that they are available 24/7. Additionally, we also provide lodging and transportation assistance. We have volunteer drivers in the community who will drive patients to and from their medical appointment free of charge. That's our Road to Recovery program. We also provide Look Good, Feel Better, which is a powerful program because we have volunteer beauty professionals, certified cosmetologists and estheticians who teach women ways to deal with appearance-related side effects of treatment. So if you haven't checked it out, enroll, because the number of the facilities in the East Bay are service host sites, including Diablo Valley Oncology. Finally, I just want to mention Reach to Recovery program, which is peer-to-peer support that's available to women diagnosed or anyone diagnosed with breast cancer. We have volunteers who are all at least a year in remission, and they are able to provide one-on-one peer support for those who are newly diagnosed or those who are looking at new treatment options, so they know that is available. Finally, the WIG program. At our office in Walnut Creek, we provide brand new wigs free of charge to patients. So if you're not aware of that, give us a call and set up an appointment, and there's really no reason to purchase a wig. Additionally, we also provide educational materials at our offices. So that in a nutshell is our summary of services. And again, if you'd like any further information in any of these programs, call our 1-800-ACS-2345. Thank you so much and enjoy the event.
Thank you, Julianne. So as you've heard, both of these organizations provide so many levels of support for our patients, so please tap into them if you haven't already. So now I'm going to introduce myself. So I'm a medical oncologist, as I mentioned, and I spend most of my practice treating breast cancer. So, how is it doing anything to the slides, obviously? Here we go. Okay. So I have 15 minutes to talk about breast cancer updates, which is basically impossible. I decided to just touch on 3 different topics in breast cancer that are pretty relevant right now. And each of these topics could be an hour, okay? But I've got 15 minutes for 3, so bear with me. I'm going to start with genomics in breast cancer. And this is kind of a hot topic right now. And I just want to start by telling you the difference between genetics and genomics, because I think that there's a very important distinction that isn't entirely obvious all the time. So when we talk about breast cancer genetics, we're talking about women who have inherited a gene in their DNA, and men, not always women, that have inherited a gene that predisposes them to developing breast cancer and potentially other types of cancers. So when we talk about someone going to see a genetic counselor and getting genetic testing, we're talking about testing their DNA in their body. And that is in every cell in their body. So that is genetic testing. And that's what leads to hereditary breast cancer risk. And about 10% of breast cancers are hereditary. But that's not what I'm talking about. I've been talking about genomics. So genomics refers to actually studying the makeup of the proteins and the genes in a tumor. And so we will often use, and more as we move forward, use genomic tools and assays to help us really look at what a breast cancer tumor is made up of. And that information can help give us prognostic information, meaning how is this breast cancer going to behave? Is it aggressive? Is it likely to metastasize or recur? We call that prognostic information. And then some of these genomic assays also give us what we call predictive information, which is telling us to be able to predict, is the treatment going to help us? What kind of treatment are we going to use? So we want to use genomic assays that give us these 2 very important pieces of information. Right now, there are a lot of genomic assays on the market. More and more are coming, and we can't talk about all of them. I'm just going to touch on one that's called an Oncotype DX, and that was the first genomic assay available for breast cancer, the most widely used, and in my opinion, as well as many others, has the best data. So I'm going to talk a bit about that for you first.
Can you repeat the name?
It's the Oncotype DX assay, and it's the company that puts out is called Genomic Health. After we talk about genomics, I'm going to just briefly mention to you 3 new drugs that were approved by the FDA in 2017 for breast cancer and tell you where those fit in our treatments. And then I'm going to touch on a very hot topic for many patients, which is how long you should be on your anti-estrogen or hormonal treatment for breast cancer. So this is a sample of an Oncotype DX report. I apologize, this is a horrible slide, very messy. But I wanted to just give you a quick view of this. And some of you in the audience, I'm sure, have had this Oncotype study done, but not everybody has. And this test is not appropriate for everybody with a newly diagnosed breast cancer. So this assay is designed for women who have early stage breast cancer, typically stage 1 breast cancer and sometimes some early stage 2 breast cancers that are hormone receptor sensitive. So their cancers are sensitive to estrogen and progesterone. and generally for women whose lymph nodes are negative, that have not been involved with cancer. And the real crux of getting this test is to help us decide if this patient needs to have chemotherapy as part of her treatment. So all women whose breast cancers are hormone sensitive are recommended to receive anti-estrogen or hormonal treatment. But then there's going to be some women who, in addition to that, will need chemotherapy as well, and that's where we order this Oncotype assay. There is some data, smaller data, that in some cases of lymph node positive breast cancers, we can consider using this assay as well and can help us in a limited group of women who have lymph node positive cancers. But it's not widely used in lymph node positive cancer at this point because generally we do give women with lymph node positive cancer chemotherapy. So if you haven't had an Oncotype, I'm sure there's a good reason why you didn't. It probably wasn't an appropriate test. But this, let's see if I can use this pointer here. Yeah, so the first page of an Oncotype will give you what's called a recurrence score. So Oncotype will test 21 genes on the breast tumor, and based on the profile of all 21 genes, they're able to come up with what's called a recurrence score. And the score is between 0 to 100, and they then break up that scale into a low-risk group, which is 0 to 18, 18 to 25 is intermediate, 18 to 30 is intermediate, and anything above 30 is high risk. So you'll get a score that will tell you if you're low, intermediate, or high risk, but also a number on that scale. And that number will then map out to a percentage, and that percentage says what is the likelihood that this breast cancer is going to recur in another part of the body or metastasize within 10 years, okay? And so in this particular Jane Doe patient, her recurrence score was 10, which is low risk, and her recurrence risk is 7% at 10 years, meaning that she has a 7% likelihood of developing metastasis in 10 years. And this assumes that this woman will have taken hormone therapy for 5 years. And in this case, most cases when they started doing this was with tamoxifen, which is one of our estrogen blockers. So that's the first page. So this woman has a low risk score. And then on the second page, they try to break down, well, if you add chemotherapy to this patient, how much benefit is it going to give you? And you can see on these two graphs that if you have a high risk score, you're going to have a big benefit from chemotherapy. It's going to improve your cure rate. If you have a low risk score, you have nothing, no benefit there. And intermediate is a little bit more benefit than low risk, but looks pretty close to low risk to me, right, when you look at that. I'm going to come back to that in a second. And then the last page, they retest the estrogen progesterone receptors when they run the Oncotype. They test it at an RNA level. And then they also test a protein called HER2, which many of you are probably familiar with. HER2 is not in the hormone pathway. It's a different gene and protein that we're looking for in breast cancer. HER2 protein positive breast cancers tend to be more aggressive, but also respond very well to treatments that involve antibodies against the HER2 protein called Herceptin, Perjeta, and some others that are out there. This assay is not intended for use with women who have HER2 positive breast cancers. So usually that HER2 should come back negative. So what's interesting here is that we have very good information that if you have a low risk score, you probably don't need to have chemotherapy. If you have a high risk score, you really probably should. But if you're in the middle, then what do you do? So a very large prospective trial is ongoing, and it's called the TAILOR-X trial. And what they did in this trial is they took women whose scores were between 11 to 25, so they changed their intermediate risk a little bit. They made it a little bit lower, so they wouldn't miss anybody. And if you had a score between 11 to 25, you got randomized to receive chemotherapy or no chemotherapy. And I did have a few patients on this trial. So the trial is close to accrual. They're still gathering the information, but they did publish part of the results in the New England Journal of Medicine. What they have published so far is looking at the group of women who had 0 to 10 scores, so really low risk, not just less than 18, but actually 10 or less. And I just think this is a fantastic piece of information. This is directly from the New England Journal of Medicine. So in women who had a score that was less than 10, so very low risk Oncotype, all these women had hormone positive tumors, lymph node negative tumors. And when you look at their 5-year overall survival, nobody had chemotherapy, 98%. So pretty amazing number, 98% cure rate. And then they broke it down into low, intermediate, and high-grade tumors. And so the grade of a tumor refers to how actively the cells are dividing under the microscope. So high-grade tumors are sometimes thought to be more aggressive. But there were high-grade patients whose score was low. They did not have chemo, and they have a 97% cure rate. So everybody's very excited about these numbers, just because it tells us how well we're doing with our treatments of breast cancer. What we're really waiting for now is the results on the 11 to 25 group, that intermediate risk score group. Are these women going to benefit from chemotherapy or not? That data's not out yet. We hope it's coming soon. I did get a little bit of a teaser at a meeting I was recently at that they are predicting that anybody less than 25 may not have a significant chemo benefit, but we don't know that just yet. Okay, so now I'm going to move on a little bit and just tell you about, there have been 3 drugs approved by the FDA this year for the treatment of breast cancer. 2 of them are very similar to each other, and 1 of them is different. So I'm actually going to go forward a slide and then come back. Okay, so my colleagues over here are going to have these really cool, pretty slides. And I thought I needed to have one. So this is an oncologist version of a cool, pretty slide. This is what we call a signal transduction pathway. And this is a breast cancer cell, or part of a breast cancer cell. This is the surface of the cell up here, and this is all inside the cell. And this is the nucleus of the cell. So just think back to your high school and college biology. And a lot of what the targets of breast cancer treatment are involve receptors that are on the surface of the cell. That's where the estrogen receptors are, that's where the HER2 receptors are. But there are all these proteins that get signaled from a receptor and go all the way down to the nucleus, which is where DNA synthesis, cell division, and protein transcription happens. And along that pathway are all these proteins, and one protein activates this protein or inhibits this protein, and it's crazy. But that's where all the research is. So I'm going to talk about right here. CDK is a protein, cyclin-dependent kinase, that is directly involved in cell division for breast cancer cells. And very close to it is the estrogen receptor signaling pathway. So in 2015, actually at this meeting, I gave you guys some information on a drug that was approved called Ibrance, or palbociclib. Palbociclib is a CDK inhibitor. So it's not chemotherapy, it's not hormonal therapy, it is a small molecule targeted agent or biologic agent. And it was the first in class to be approved for the treatment of breast cancer. It is currently approved for women who have metastatic or stage 4 breast cancer. So their breast cancer has gone to other parts of the body, and they are on treatment for their breast cancer. And it was approved in 2015. It got accelerated approval through the FDA, which is hard to get because its data was so good. And when they combined Ibrance, or palbociclib, with hormonal therapy, and they initially used an aromatase inhibitor called letrozole, or Femara, there was a significant improvement in what we call progression-free survival when you added this drug. And so it was such a good improvement that the FDA said, we got to prove this quickly based on phase 2 data. Usually the FDA waits for phase 3 data. So this came out in 2015. I still, to this day, have many patients who started it as soon as it came out, and they're still in remission 2.5 years later. So very remarkable treatment that has helped a lot of people. So Ibrance was very happy in this space, in this pharmaceutical world, until this year. And 2 other companies have now gotten FDA approval for CDK inhibitors as well. One of them is ribociclib, or Kisqali, and it's very similar to Ibrance, and it's approved in the same treatment used with hormonal therapy. It can be used with the aromatase inhibitors as well, which are oral estrogen blockers. I didn't mention that Ibrance can also be used with fulvestrant, which is an injection that someone will receive to block their estrogen. And then just within the last couple of months, abemaciclib, or Verzenio, was approved, another CDK inhibitor, and it can also be used with hormonal therapy. And they, interestingly, now have some data that it can be used by itself. So we're all trying to figure out where we work all of these new drugs into our treatments, but we're very excited to have this class of drugs that really has pretty minimal side effects and is very effective against breast cancer. And it works because of this, the fact we call it dual inhibition. You're going to be blocking an estrogen pathway and the CDK pathway at the same time. So it's really trying to outsmart these cancer cells that find ways around when we block pathways. And then the last drug that was approved very recently is a drug called neratinib, or Nerlynx. So this is for women who have HER2 positive breast cancer, early stage, so stages 1 to 3. And HER2 positive, as I mentioned earlier, is a protein that when it's overexpressed, it does make the breast cancer more aggressive, but these tumors also respond very well to HER2-directed therapy. So women will standardly receive chemotherapy with Herceptin, which is an antibody to HER2. They may receive another antibody called Perjeta, and the Herceptin goes on for a year. So women will typically have about a 5-month course of chemo with Herceptin, and then after that they have 7 more months of just Herceptin, the antibody alone. This drug was approved to use when you're done with your year of Herceptin. It's a pill that you take every day. And let me show you my other pretty slide. It is a small molecule inhibitor that inhibits, these are all different types of HER receptors, and it, right when you cross the cell membrane here, it's an intracellular protein, and this is where neratinib, or Nerlynx, inhibits HER2. So it doesn't inhibit it the way Herceptin and Perjeta do at the receptor out here. It's once you get inside the cell. So it's a different mechanism. And the idea being if you use a different mechanism to block HER2, maybe you'll get even better benefit. So women take this drug orally for a year. The benefit is 2%. Okay, so it's not a huge benefit, but it is a benefit. The majority of the women who were in this trial had lymph node positive disease, about 75% of them. And that 2%, it's small because they're already doing really well, right? So if you look at this, without the neratinib, they had a 92% cure rate, and with it, 94%. So we're doing well, and we can do a little bit better. The question now is, at what cost? So first of all, these drugs are expensive, but second of all, they can add toxicity, and this drug causes a lot of diarrhea. And they report in the study about 40% of women have diarrhea, 17% have so much diarrhea that they can't take the drug. And they are actually, the drug companies recommending you start Imodium the first day you start the pill. So, you know, it's a discussion. I actually have not had a patient use it yet, and I think it's something that you have to kind of individually decide how much more you want to do for a couple % benefit. I think it's worthwhile to think about women who have more aggressive tumors or have maybe lymph nodes positive. And actually, interestingly, women who had hormone positive tumors, estrogen positive, did get even more benefit than the ones who had hormone negative. So it can be given with the hormonal therapy, but we'll have to see how the toxicity works out. So this is brand new. The follow-up data on the study is only 2 years, which is considered short. And so some of the critics of the study are wondering if this benefit's going to persist after we follow it for longer. Maybe the benefit will be greater over a longer time, so time will tell. But this is brand new. And then the last thing, again, this is like 2-hour talk I could give here, is how long should we keep you guys on your estrogen blockers? So about 75% of women with breast cancer will have hormone-positive breast cancer. And for many years, the standard was to be on a hormone blocker for 5 years. A few years ago, the ATLAS trial came out, and I've talked about that at this meeting as well. The ATLAS trial is looking at tamoxifen. So tamoxifen is one of our estrogen blockers that works in both pre- and postmenopausal women. And the ATLAS trial was a huge trial, I think something like 5,000 women. And they found that if you took tamoxifen for 10 years rather than 5 years, you had a 2.6% improvement in survival. And they particularly saw this benefit in the later years. So we do sometimes hear about women whose breast cancer comes back late, year 8, year 11. Someone today asked me about Olivia Newton-John, who's year 23. That's quite an outlier. But the benefit of tamoxifen for 10 years seems to be in those later years for women who might have had a recurrence later, had fewer recurrences if they took their estrogen blocker for longer. So then the question was, well, what about the aromatase inhibitors? And that's the other class of hormone blockers that are very widely used for postmenopausal women. And the standard has been, and still is at this moment, 5 years. The initial study that came out many years ago was the MA17 trial, which looked at women who took tamoxifen for 5 years, and then they either finished or they took an aromatase inhibitor for 5 years. And at that time, that study was with letrozole, which is Femara, and they had a significant benefit if they continued taking a different hormone blocker, so now an aromatase inhibitor for 5 more years. So the extension of that study is what got published in June of 2016. It's the MA17R trial. And we were all waiting for this trial. So this was, if you've been on aromatase inhibitor for 5 years, what happens if you take it for 10, just like the Atlas trial for tamoxifen. And this study showed the disease-free survival to improve after 5 years of follow-up from 91% to 95%. So a small benefit, but a benefit nonetheless, just like the tamoxifen benefit. The benefit was mostly seen in preventing recurrence in the same breast where the cancer was if someone had kept their breast, did not have a mastectomy, or in reducing the risk of getting a new cancer on the other side. It did not have as much of a significant benefit in metastasis to the organs and bones. So it was kind of disappointing because that was really what we were looking for. But based on that, we started to talk about the option of continuing for 10 years. And then, just to shake it up a little bit, a year ago in December, the 3 more trials came out, were presented at our San Antonio conference. The DATA trial, the IDEAL trial, and NSABP-42. These were all 3 trials looking at the same thing, which is, should we be on aromatase inhibitors for 10 years or 5? All 3 of these trials did not show a benefit. These trials all have shorter follow-up than the MA17R trial, so it might be that we'll see a benefit as we follow these trials longer, but now we're kind of back to, well, maybe we should be stopping at 5 years. And so the consensus now amongst breast cancer experts is this decision to continue beyond 5 years is an individual decision that has to be made between the patient and their physician based on what is their risk of recurrence. People who might have higher risk, more positive lymph nodes or more aggressive tumors might consider staying on longer. Low risk, small stage 1 tumors may stop at 5 years. And then you also have to look at how it's affecting your quality of life. And aromatase inhibitors can absolutely affect your quality of life, as I know many of you are aware of. And sometimes it's a small effect on quality of life, and sometimes it's huge. Side effects can be quite difficult with blocking estrogen for so many years. We also look at bone density, which is very important. These aromatase inhibitors can cause bone loss. So all of these things play into making this very important decision as to how long you should stay on your hormone blocker. So the jury is still out. And I think that's my last slide. So now I would like to introduce Christine Chung. She is a radiation oncologist at Diablo Valley Oncology. She's one of my partners. She's one of my friends, and she's brilliant. So I'd like to invite Christine.
Hello there, I'm Christine Chung. I'm a radiation oncologist, and I see some familiar faces. Thank you for coming and spending your morning with us. Today I'm going to talk about a few things. I've decided to start with a brief overview of radiation just to make sure we're on the same page, talk about the side effects of radiation, and then how I should take care of myself during treatment. And there have been some new developments in terms of looking at long-term side effects of breast radiation, and I thought I'd focus on those. So why do we use radiation? Well, radiation is a high-energy X-ray that's used to lower the risk of breast cancer coming back in the same area. So while Dr. Swan works with treatments like chemotherapy and hormone blockers that can work for your whole body and lower the risk of breast cancer coming back anywhere in the body, radiation is really a local treatment. It's like a flashlight that we shine at one area to lower the risk of breast cancer coming back just in that area. So here you see a picture of the breast, and these green lines are the lymph vessels. The lymph vessels carry immune cells throughout your whole body. They're a railroad system through your whole body, and these green round structures are the lymph nodes, and those lymph nodes are like the railroad stations along the pathway. And sometimes the cancer cells can hop onto this railroad system and get stuck in the lymph nodes. And radiation is used after surgery, so after a lumpectomy or sometimes after mastectomy, to lower the risk of breast cancer coming back in these areas. And we know from a number of different older trials that radiation significantly lowers the risk of breast cancer coming back in the same area, which is what we call local recurrence. Here we can see the results of 4 different trials that showed that radiation lowered the risk of breast cancer coming back in the same breast 20 years after the surgery. Women who just had surgery had up to a 40% risk of the breast cancer coming back after lumpectomy, and this risk improved to about 14% if you added radiation. And mind you, that risk is lowered even further if you have chemotherapy or hormone blockers. And by lowering that risk of local failure, you actually improve survival. And this was a big, big study done in Oxford where they combined the results of many different trials. It's called a meta-analysis. And they showed that over a 10-year period, you significantly lowered the risk of breast cancer recurrence by about 15%. And over here, this is breast cancer survival. That actually, lowering the risk of the breast cancer coming back in the same breast actually helped improve survival 20 years down the line. Now, how does radiation work? So radiation, as I said, is a high energy X-ray. It creates free radicals, and those free radicals cause DNA damage. And that DNA damage then leads to biological effects like death of rapidly dividing cells. And the cells in the area that we're treating that are dividing the most quickly are the breast cancer cells. So how does a patient get treated? The first step is to do a radiation planning session, which is called a simulation. And it's a mapping session that we generally do now with CT scans. And then the radiation oncologist works with our team of physicists and dosimetrists to put together a plan, and then the treatment is delivered. Each treatment is called a fraction. It's given generally 5 fractions per week, 5 to 10 minutes per treatment. And the total number of treatments and the dose per fraction, so the dose per treatment, depends on the intent or the goal of the treatment. If we're planning to treat for cure, which is what we call radical treatment, the treatment is given over 3 to 6 weeks. And for palliative treatment, it's given over 2 to 3 weeks. And palliative treatment is used in situations in which patients have stage 4 metastatic breast cancer, where the breast cancer is already spread beyond the breast and lymph node areas. And the goal of treatment at that point is to help with pain or to help with other symptoms. Here is a picture of a breast. This is a patient lying on her back with the head of the patient going into the page. This is the right side, this is the left side. And here we develop what looks like a topographic map of dose. And so you can see the red area is the area that's getting full dose radiation to the left breast. Now we know that every treatment has its potential side effects in addition to its benefits. So for radiation, because it's a local treatment, all the benefits are local and all the side effects are local. Some complications can occur during treatment or days to weeks right after treatment, and some complications may occur weeks to years later, and those are the long-term side effects. So the early side effects occur days to weeks after treatment, and they develop in the tissues that are dividing the most quickly, so the cells that are dividing the most quickly, namely the skin cells. And the damage may be completely reversible. The side effects include skin irritation, possible blistering and peeling, breast pain, temporary hair loss in the treatment area, and skin darkening. The most common side effect associated with radiation is fatigue, and it's usually not debilitating. Most women continue to do all their normal activities. They can go to work, they can drive themselves, but it can be pretty significant. A brief word about skin irritation. So about 95% of patients who receive breast radiation develop some sort of skin irritation as a result of treatment. They may not notice any irritation for the first 2 weeks of treatment. And the skin reaction is usually mild to moderate. It really varies from person to person, and it's not predictable up front depending on your skin tone or your sensitivity to sunlight. As treatment continues, more serious skin irritation may occur, and 20 to 25% of patients may develop blisters or moist peeling of the skin. So here are some images. In fair-skinned women, oftentimes the skin irritation manifests as reddening, and in darker-skinned women, it often manifests as skin darkening. And so These are the different stages of skin irritation. This is very mild irritation, so about 2 weeks in, one may expect some mild irritation of the skin. This can become more severe with itchiness of the skin developing, and that can progress to further blistering and peeling of the skin, which can be painful. So how should one take care of their skin? Recommendations are to keep your skin clean and dry, not to scrub the treatment area in the shower, and to use lukewarm water and a mild soap like Dove, to avoid extreme temperatures, and to avoid using hot tubs or saunas just in that area. Some people like to submerge halfway. That's fine. It's really the local area that we're concerned about. Do not use an electric heating pad, hot water bottle, or ice packs in the treatment area. Avoid perfumes and antiperspirants, which can irritate the skin. And do not use adhesive tape or Band-Aids on the treatment area. Also, don't shave the treatment area with a razor in that underarm, because that can be really irritating. Wear soft, comfortable, loose-fitted clothing. And if your skin's irritated, I highly recommend avoiding wearing a bra, because that bra strap can be really irritating, particularly the underwire. So I recommend wearing a soft camisole or soft bra if you really mess without an underwire. Avoid clothes that rub or constrict your skin, such as tight collars or straps. And if your skin becomes irritated, you can use a water-based moisturizer during the day. We often recommend calendula lotion. You can also use aloe or Aquaphor or Lubriderm. And you may want to bring the lotion with you to clinic and apply before you change back into street clothing, and avoid moisturizers with harsh perfumes or alcohol. If you develop itchiness on your skin, you can use topical steroid creams such as 1% hydrocortisone. And then if you need to, your radiation oncologist can prescribe more stronger cortisone creams. So long-term side effects are of particular interest in patients who've had breast radiation. These side effects can occur months to years after treatment, and the damage is not completely reparable, so these can be permanent side effects. The most common side effects involve the breast. There can be mild shrinkage of the breast, increased breast firmness, and mild skin changes of the skin or the areola. There are potential long-term side effects to the lung, to the heart, lymphedema, or second cancers. And I'm going to talk more specifically about the heart and lung side effects. So this was a study that was published in the New England Journal in 2013. It continues to get a lot of press, and so some of you may have heard of it. It was published by Darby et al., and they looked at thousands of women in a database from Sweden and Denmark. So it was a study that looked at a database of patients. And in these Scandinavian countries, they follow the patients forever. So they have long-term data for years and years. And what they showed is they looked at breast cancer patients who had gotten radiation, and they showed that the relative risk of a cardiac event increased with the mean dose to the heart by 7.4%. What does that mean? And I want to be very clear about this because it's a scary number, and I want this to be very clear. The absolute risk, so when you say, what is my risk of having a cardiac event like a heart attack, requiring a coronary catheterization, or dying from ischemic heart disease, was very low. It was 0.5% to 3.5%. So the actual number is low. So what does this 7.4% per grain mean? That's the relative risk. So that's, if you have something that's 1% and that goes to 2%, that's a 50% relative risk increase. You have to look at the baseline to know where that relative risk comes from. So while it was a 7.4% increase per grade, that is a relative risk. The actual number that you're looking at is still very low. It's 0.5% to 3.5%. And so they had some examples in the article of, a woman's 50 years old and has left-sided breast cancer. That risk, depending on other risk factors, like whether the person smokes or whether they have a history of heart disease, that risk is really in the order of 0.5 to 3.5%. So it's a very low risk. That is the take-home message. You may hear the 7.4% per grade number. That is not the real risk of you yourself developing heart disease as a result of the breast radiation. And the risk was higher among patients with a history of cardiac risk factors like high blood pressure, high cholesterol, or prior cardiac events. So this study had its problems, like every study does, and they looked at the database of patients. They looked at what kind of the treatment the patients got, and then they tried to extrapolate using our current CT methods to estimate how much heart dose there actually was. And so another point to really keep in mind is that the techniques we use now to treat breast cancer are very different from the techniques that were used even a decade ago. And so this study examined patients treated between 1958 and 2001, so older techniques were used to deliver the radiation. The average heart dose was 4.9 gray. So gray is our unit, it's just like centimeters or inches, except that's the unit for dose for breast cancer treatments in this study. And more modern techniques show a mean heart dose of 1 to 2 gray. So the total dose that the heart receives now is very different from what it received back then. So even this estimate of 1 to 3.5% is likely an overestimate if we look at the techniques that we're using currently. There is also a risk of second cancers after breast radiation. Overall, that risk is 1%. It's a very low risk. In that 1%, there is a risk of lung cancer, as well as a risk of sarcomas, which is the risk of a second cancer of the muscle or the bone in the area that was treated. And oftentimes it's the area that didn't receive full dose, but the area that received kind of lower dose. So there's a study that was just published that looked at the risk among smokers versus non-smokers. And now we know already that if a person smokes, that person has a higher lifetime risk of developing lung cancer and dying from lung cancer. And so this study estimated that smokers had a 9.4% risk of dying from lung cancer. And if you added radiation to the breast, that risk increased to 13.8%. Now, if somebody had never smoked, the risk of dying from lung cancer was 0.5% over their lifetime. And then if you added radiation to the breast, that risk increased to 0.8%. So it's still a very low risk, particularly among non-smokers. Now, even if somebody does smoke, it's never too late to quit. When they estimated smoking, the risk of death from lung cancer, if somebody stopped smoking at the time of radiation, it decreases that risk of dying from lung cancer it decreased that additional risk from 4.4% to 1.3%. So you're almost taking your risk down to baseline if you stop smoking, even at the time of diagnosis. So the take-home message there is it's never too late to stop smoking. Now, in that study, they looked at, again, historical data. In that study, the average historical lung dose was 10 gray. The average modern dose is 5 gray. Now, how are we doing this, lowering the heart and the lung dose? And one of the ways we do it is that we use 3D radiation planning systems, which are becoming more and more sophisticated with every year. And like I said, part of the planning is that we do a CT scan up front, and then we use those CT images to plan how the radiation beams are going to go in to minimize radiation to the heart, which are these black structures, or the lungs. The heart, which is here, and then the lungs are the black structures. So one of the new systems that we have currently adopted at DVO is SDX. And it's a technology that allows for a reproducible breath hold with each radiation treatment. Now, in this picture, imagine if we took a deep breath and filled the lungs up with air, that would push the chest wall out, and that would increase this distance between the back, the breast, and the heart. And that's what we're doing with the breath hold for left-sided breast cancers. The breath hold technique allows an increased distance from the heart to the breast, thereby lowering the radiation dose to the heart. And so here's a picture of this fancy machine. It's a mouthpiece that's attached to a computer, and the computer then is hooked up to these fancy goggles. You have a nose plug, and these goggles are like a video game or virtual reality. You can look inside the goggles, And you can actually see your respiratory cycle. You can see as you inhale, take a deep breath, you can see the line go up. As you exhale, the line goes down. And then there's a target range in which we will request you to hold your breath. And that breath hold is for about 30 seconds, so it's not like you have to hold your breath for 5 minutes. And even doing that short breath hold allows us to treat only when your breast is in the optimal position to lower radiation dose to the heart and lungs. So we are routinely doing that for patients with left-sided breast cancers. Just a few final words. Taking care of yourself during radiation, get plenty of rest, listen to your body. I highly recommend exercising. That's the only thing that's been shown to help improve fatigue associated with radiation. But at the same time, you have to balance that against the fatigue associated with radiation. And then just leading into our next speaker, try to eat a well-balanced diet with enough calories and protein. I welcome any additional questions. Thanks.
Thank you, Christine. I always learn something when I listen to her. I forgot to ask to hand out the questions or hand in the questions that you guys may have from the first two talks. So I have a couple people walking around. Sandy and Shayna there. Okay, great. So now I'm going to introduce Dr. Timothy Leach, and he is the head of OBGYN at John Muir Walnut Creek. I've been working with Tim since I came to work in this community over 11 years ago, and I can't begin to tell you how much he adds for the care of our breast cancer patients. And Tim and I were on TV last week together. We did a nice little program. Maybe some of you caught it. So this is Dr. Tim.
So you go to talks and you sit there for 20 or 30 minutes and you're like rapidly taking notes and trying to remember everything, and then you end up going home and you're like, maybe one or two things from that talk. So I'm hopeful that at the end of this you'll remember maybe three or four things. So, but I don't want you to take any notes because the entire talk is on a little business card that's on a flash drive that you can take at the end over there. And on that flash drive has a lot of other information, and you'll kind of see reference within the talk here as far as websites or other resources and services. And so I just want you to listen, and I want to kind of fly through these slides pretty fast, and they're all on that slide deck there. So, so with that, this talk is about kind of lost and found. It says, he's not here. If you're lost without him, you can always stay and see if he tries to find you. So this is an important organization. It's the North American Menopausal Society, and that's their web address. Huge advocacy for menopausal patients, both physicians and patients. I'm a certified menopausal practitioner, which means I took a little test for 4 hours and demonstrated a proficiency. Many of you might know Sandy Altman, who was a friend and colleague who passed away several years ago from a brain lymphoma. She was the menopausal maven for many years and was an advocate for menopausal care in the community. When she passed away, there really wasn't anybody else doing it, and there was a huge need, and my practice started to evolve several years ago to include this. But this is a wonderful organization and has a lot of patient education that's very helpful. ISHWISH is an organization I've just become recently familiar with, which is devoted to the sexual health of both men and women. And it's an international society. It's made up of psychologists, psychiatrists, gynecologists, urologists, physical therapists. I mean, a very multidisciplinary team of care providers who help both men and women when dysfunction might exist between the ears, in the lumbosacral region, or at the penis and or vagina. So another organization that you can use as a resource for information. So today, I'm going to limit our little talk here, which is the point. So today, we're going to talk specifically about genital pelvic pain, but again, female sexual dysfunction can arise from desire to arousal to orgasmic to actually, uncontrollable pain that's not voluntary. We're going to specifically limit this little talk right here because, again, I could talk for any one of these for, a long period of time. So this is a very detailed slide, but it's just to sort of, again, demonstrate that there's nerves, muscles, ligaments, and these are all very hormonally sensitive, and they can all be affected both by menopause and cancer chemotherapy. These are the steroid pathways, and it starts out here with cholesterol, winding up down here with estrogen, testosterone, which are most of the hormones that most of us are familiar with. But there are these hormones that have a play in that biology, and then this is the cycle here that can involve the sexual response. And so you can see that it also incorporates sort of the biopsychosocial, so it's not just about sort of the end organ, it's about sociocultural, psychological, interpersonal. So again, it's complicated, okay? So there's this overlap, and again, I'm going to limit my little talk right down here today to talk about dysprunia, which is a medical term for refer to painful intimacy. So again, I'm going to be very specific about the difference between sex and intimacy. So definition of sex is the sum of the structural, functional, behavioral characteristic organisms that are involved in reproduction. I can go through it right here. An intimate quality, state such as emotional warmth and closeness. We're going to talk specifically about sex to the extent with respect to pain and discomfort and how to overcome some of those limitations that both menopause and cancer can introduce into a woman's life, into her relationship. So it says the magic's still there, but the sex is not the same. And again, I think the magic is the intimacy, but the sex is actually the physical discomfort that oftentimes accompanies menopause and these cancer chemotherapeutic agents. So menopause. 50% of women are done having a menstrual cycle for 12 months at 51 years of age. So some are done before, some are done after, but it happens. And 50% of women by 51 years of age. And it can bring on not just symptoms of hot flashes and night sweats, but changes in body image and reflection on this part of a woman's life. And again, can have profound impacts that all can lead to a difference. And so then you have cancer on top of it. Now you've got two things that are sort of impacting overall sense of health or wellness. And this really kind of, again, gets to the point about it's complicated, and it can, again, involve a very complicated interplay of pain medicine, physical therapy, other assisted products, counseling, sometimes couples. But it has to be individualized for a woman's particular needs. So again, female sexual dysfunction, menopause, and aging. Again, talking about changes that occur in the midlife and beyond. Patients are not aware that actually that lack of estrogen, that simple loss of estrogen, can change nerve function, then can change blood flow, and that can impact or arousal and orgasmic response. This is a project that's under the National Institute of Aging, which is at NIH, and it kind of talks about just a summary of how important this and intimacy and sex are for women, and just sort of a frequency of different types of intimacy. But down here, 22% of women reported having discussed it. So over 80% of women, have not even had a conversation, oftentimes because they are uncomfortable bringing up, and physicians may be even uncomfortable broaching the subject. So this transition can actually get worse over time. And so I tell my patients that the hot flashes and night sweats, if you are a patient and you just sort of gut it out, 90% of patients will actually probably have a diminution or a resolution of them within about 5 to 7 years. But these changes that happen in genitopelvic changes slowly get worse and only get worse over time. So it's not something that just patience and time is really going to be your best plan. And it all kind of starts out as a loss of estrogen. It's just a key important hormone, and its decline is then associated with these increases in pain, specifically with intimacy. And these are many surveys here that are sort of trying to, again, query women about the effects of this loss of estrogen on their genitopelvic health, and that it's consistent that GSM, which is the medical term, it used to be vaginal atrophy, and that's such a negative connotation that the professional organizations got together several years ago and returned the diagnosis to genitourinary syndrome, because it really involves both the vagina and the bladder, of menopause. And so that's what's referred to now professionally when we talk about GSM. So we're trying to, again, describe the term and not have the negative connotations that the old terms had. So, but they're important to overall sense of health and wellness. And again, negative effects just simply vaginal discomfort can have on overall life. These are the symptoms that can occur that can lead to urinary tract infection, soreness, burning, itching. I mean, none of this sounds good. I'm talking to the choir here. But the sad thing is that many women do not talk about it, or doctors don't talk about it, and it gets underaddressed, undertreated, and patients kind of figure out, okay, this is the new norm. And I'm here to tell you that that is not the case, and we have wonderful paradigms, even newer paradigms I'll share with you, and it's just something that we all have to be more comfortable talking about and raising those questions with your providers. If your provider's not comfortable, then finding a provider who is comfortable. And the North American Menopausal Society has a physician locator. So you might have somebody who doesn't live in California but is having the same questions. They can go on that website, find a physician locator, and that's going to be somebody who is experienced and comfortable having a conversation about these topics. It's very prevalent, extremely common, and again, underaddressed, and that's my goal to overcome that. So again, this is just a little picture that kind of shows changes that can happen over time with that loss of estrogen. So again, this is called the vestibule here, labia minora here, labia majora out here, and over time, all these tissues without estrogen, including the minora, the vulva, the perineum, can shorten, can stenose, and patients are oftentimes surprised when I say that it actually can get smaller over time. And they're like, it what? And I tell them, sadly, your husband's penis only gets to one size and will never get to a different size. So it really then becomes a mismatch. And part of what I'm going to help you know about is how to try to sort of realign those two parts of that relationship so that it continues to be one that is nurturing and loving. So, but it is true, it is a sort of use it or lose it. Now, it doesn't mean you have to have sex all the time, but it does mean there needs to be some sort of regular stretch, some regular exercise, regular sort of use of that epithelium feeling something inside. And it's not just about taking hormones so that it feels better. You actually physically have to use something to maintain the actual capacitance of the vestibule here. Okay, so this is just a comment on estrogen and how it changes the urogenital tract. Oh, there we go. So this is, again, what it looks like here. This is a picture that kind of tries to show you in a normal, healthy, premenopausal vagina, it's pink, it's vascular, it's foldy. These are like folds called rugae that act like an accordion. So when there's something inside, those stretch and allow for greater capacitance. And then in menopause, it becomes pale and flat and white, and oftentimes associated with discomfort. This is, again, just if you think of terms of sitting on a cushion with a nice soft cushion versus a hard bench, okay? And that's, again, what kind of happens to the tissues or to the lining of the vagina in menopause. So estrogen is the treatment. Estrogen is the reason that, the loss of estrogen is why these symptoms occur. So treating the vagina with estrogen is a way to relieve these symptoms. Now, estrogen, whenever it's prescribed, is prescribed in what's called class labeling. So when you read the package insert of your Premarin, or you read the package insert of your oral estradiol, it'll tell you about the risks and benefits, and it'll talk about the WHI trial, and it'll talk about blood clots and breast cancer. And because estrogen in small dosages in the vagina is still estrogen, those same warnings come on those same packages. And so patients see this package insert when they give them the pills and creams, are like, Dr. Leach, this causes breast cancer and blood clots. That's probably not likely, but it is still part of the labeling because estrogen is just kind of globally labeled with class labeling. The American College of OBGYN has gone to the FDA and said, please take those off, because a patient reads that insert and said, Dr. Leach, this is going to cause me to have blood clot. Unlikely, but unlikely is going to have an adverse impact like a blood clot or significant risk for breast cancer. And we continue to work with the FDA to try to get that out of the package insert so patients aren't afraid when they go home and they open it up, their husband says, what are you taking here? So, but just be aware that it's really about trying to then replace estrogen to the tissues you need the most. Now, that can be given systemically, but even about 30% of women who take systemic replacement therapy don't get relief of their genitourinary symptoms. So we have targeted therapies that can be rings, creams, pills, and a new soft gel tablet that's actually just been approved, which is a novel new treatment, and I'll talk about that. So again, these are the different products that are available. Again, very low dose because the actual amount is low, and typically the dosing is only a couple times a week. So that's how we can give the patient an unopposed estrogen and not worry about uterine cancer, or really believe that her risk for recurrence in her breast is extremely low. But low doesn't mean no. And when patients have breast cancer, the thought of using the word or speaking the word estrogen can oftentimes be a very fearful thought. So again, these are the products here. So creams are messy, and long-term compliance is about 15%. So it works, but it just only works if you use it. But patients don't like the long-term side effect profile of how it's administered, and so then might not use it long term. This is a tab, this little baby aspirin right here. This little tab, this little introduced like a tampon. You put it in, push a little plunger here, it drops this little tablet. So the tablet goes all the way up the top of the vagina. This actually was the old amount. It's actually now 10 micrograms. It used to be 25. And this is dosed twice a week. It's like a little baby aspirin. It's not messy, not goopy. It really addresses the vagina's needs, but when the vestibule is asked, how are you doing, which is the opening of the vagina, the vestibule says, I'm not really feeling, that well. So the medicine works, it's low dose, but it doesn't necessarily deal with the entire genital tract that estrogen used to provide health to both the labia minora, the vulva, the vestibule. So, so it's low dose, it's convenient, but it may not meet a woman's needs. So DHEA, this is a brand new product. First we've had approved probably the last 20 years. So in that steroid hormone picture that you'll be able to reference on the business card, you'll see DHEA as part of the cascade in the hormone synthesis. And this is actually a precursor to estrogen and testosterone. So it's possible now to put DHEA in the vagina. It's actually put in daily, which helps with compliance. It's a soft gel tablet, so it probably has a little bit more of a field effect as opposed to the tablet being placed in the upper vagina. And it's absorbed as DHEA, it circulates as DHEA, and it undergoes an intracellular, that complicated slide Dr. Savan had previously, it undergoes an intracellular conversion to estrogen and testosterone. So the nice thing is that it's not circulating as free estrogen, and it actually converts to both estrogen and testosterone. And for the first time within the menopausal sort of discussions and convocations, we're talking about using testosterone at the vulva, which we've never really talked about. It's largely been estrogen, estrogen, estrogen. But now we're having more of a conversation about how testosterone can improve tissue health and ossification and blood vessels and overall genital pelvic health. And so this is it's approved, it's available now in the pharmacies, and it's daily. And it can be used, again, for GSM. And it's not been studied in breast cancer patients, but again, the thought would be that it's really not circulating as estrogen, and the overall levels didn't change in the studies, and so presumably it would be, safe. Okay, so so those just kind of go through some of the diagnoses and definitions and treatments for GSM. Now, there's also other treatments that may be considered first, and that can be lubricants and moisturizers, and what I will call other assisted devices. Okay, so now if you don't smoke, that's good for a lot of things, including your vagina. And then the other idea would be moisturizers, lubricants, dilators, and a fractional CO2 laser here. Okay, so moisturizer, just like when your skin is dry in your hands, your vagina can be dry as well. So putting on a moisturizing agent, which can then hold more water, and again, just give the tissues more relief, is something that someone can use daily. These are some of the products here that are out. This is, again, what these products look like here. Lubricants are more used for actually friction and for actual use with insertion, whether it's a penis, a vibrator, or a dilator. And they come in different types, whether water-based water-based or silicone-based. And so again, here are some different products here, just for reference. This is again sort of information about how to choose a lubricant, which you can look at on this little slide card. These are again some other thoughts on why you might choose water versus silicone. Also a consideration if you're using other assisted devices. Again, why are they used? Primarily, again, for comfort, more when you're using your vagina with respect to either a dilator vibrator or with intimacy. Okay, so dilators, okay? So I actually have some, brought them with me. This is kind of the show and tell part of the show. Okay, so the other thing I brought is what I call the penile profile measure, which is no more than a little sort of thing we used to do on babies' heads in the labor delivery, okay? And we used to do those pictures labor and delivery, what we didn't know is that Similac was all over their little foreheads there as a subtle way of advertising. So the hospital got rid of those, but you can still buy these paper tape, okay? And this would be no different than the cloth tape that my mom used to use when she was, sewing when I was younger. But this little paper tape can actually be used around the circumference of the penis so that a woman can know how big does my husband's penis get? Because they do come in different shapes and sizes, and some men have a smaller penis, in which case in menopause that woman is more blessed. And then when her husband's penis is bigger, there may be more that needs to be done to help maintain her level of comfort. But this is how someone can kind of know, where does my husband's penis get to? I had a patient recently come in, who's not a cancer survivor, she's menopausal, and she said after 40 years of marriage, her husband said, you know what, I'm done with sex. I've had enough. And she said, well, I'm not done. And so she said, that's fine, I'll go buy myself a vibrator. So she bought a vibrator, and she said it hurt, and she said it didn't work. And she came in, she said, so I guess, am I done with sex, Dr. Leach? And I said, well, how did you buy the one you bought? How did you, there was a fancy color with different settings and all kinds of things, you know? And so I said, well, maybe you just bought one that was too big. And she's like, what do you mean too big? And so I actually helped her with what I call the vaginal capacitance, which is a dilator that I can place. And when she said, well, this was not uncomfortable, and she said, that's slightly uncomfortable, then she could know where the circumference of the vestibule was that was now her limit. And that this was the vibrator that she bought, and that this was painful. So just helping her know, well, okay, that circumference is something that I now have information on. And you'll see here at their website here, the actual circumference of these dilators here, there's a diameter that goes along with it. There's a diameter and a length. So when you go online to buy something, you're buying a diameter and a length, but you can't measure the diameter of your husband's penis. So having this dilator can then go back to give her the diameter. And I said, just go to the section and get the 1 1/4 inches and smaller, and you'll be fine. She was like, okay, I would have never thought that that was how I was going to kind of figure this out. So some very practical, helpful, simple things to do that can then help a woman not necessarily give up on her sex life, though her husband decided that he was done with his. So Soul Source, this is a product out of LA. We have these in the office here, and their website will have the measurements. And again, in the office, we do these capacitances all the time to kind of help patients realize where am I at, and then the paper tape can help them know where do I need to get to, and then how do we put a plan in place so that we can kind of match that up. So again, this is information about choosing a vibrator, which I'm not here to talk about. Not today. Not today. But to talk about the difference between external and internal, okay? So sometimes I ask, so I've become very comfortable in the last couple of years, which I wasn't the first 17 years of my practice, with asking and talking, and patients are so appreciative when you do, but being very specific, because when I say you give a vibrator, and over 60% of women will use or have a vibrator as a part of their intimate life, I have to be specific about, is it an internal one or an external one? Because using an external vibrator, great for self-care, but it does not stretch the vestibule. It does not help maintain that sort of opening to a level of comfort that is only going to be achieved by putting something on the inside. And I will tell you, there's probably nothing more boring than putting something like this in for 20 minutes and just kind of watching Oprah. So it's very specific about internal or external. And ideally, you'll buy one that is the size or close to your partner's penis, or one that's stretching as well as providing some self-care, because you will hear that it does require some regular attention. Just like everything, heart health, food health, cardiovascular health, it's something that has to be a paradigm that becomes part of our sort of daily life. Okay, Middlesex MD is a wonderful website, professional website. I put that up there specifically so you can see it on the flash drive that has information about how to choose a lubricant, how to choose a vibrator. There's an article about sex after breast cancer, and a very responsible, put together by OBGYN physicians, highly respectful, highly professional. Again, it's just a source of information for patients who are looking like, where do I go? Sex and breast cancer, and you'll see all kinds of stuff come up, on the Google list. So Middlesex MD is a very nice website. Okay, so new paradigms. So one of the things that I'm just going to show you is this little device here. Now it's kind of hard to see, okay? But it looks like a little tiny plant, okay? And it's called Fiera, F-I-E-R-A. And you can see it at Middlesex MD's website, okay? But this is, again, what I refer to as kind of more of an assistive device. So this is a little device that's a hands-free device that actually sits in between the labiomineural folds right over the clitoris. And what it does is it creates a little negative pressure. So it actually has a little suction cup. So it's a hands-free device. And that little negative suction draws blood flow in, which helps to promote a tissue response. And then you actually have different settings where it doesn't vibrate as much as it sort of rotates on some little sort of little dials on the inside of this little. And it's not meant to bring a woman to an orgasm. It's really meant to kind of prepare the vestibule, to prepare the vagina. And patients are oftentimes surprised when I tell them it can sometimes take 20 to 30 minutes of preparation before you're comfortable with having something inside, whether it's a dilator, a vibrator, or a penis. And so just even patients recognizing that, okay, this is going to take some time, and holding something someplace or doing something that may just be even sometimes hard for persons to do. So this is, again, an assisted device. It helps to maximize tissue function that can, again, promote overall genitopelvic health, okay? So that's these new paradigms, okay? Now the paradigm I'm going to share with you today as well is called Mona Lisa Touch. So I started doing menopausal medicine, and it was wonderful learning. It can just be a wonderful new education after 20 years of practice. Baby come out the same way, surgery done the same way. And menopausal medicine was just this new area of interest, this new area of study, and this new science I didn't really know a lot about. And so I started doing that, and then just kind of along the way, it was a very random sort of finding, or a random meeting I had at a doctor's office where I heard about this laser in the vagina, and I was like, who's going to put a laser in their vagina? That doesn't make any sense. That's crazy. You're just a rep going to sell me anything and tell me anything, because reps come along and they tell you and they promise you the world, and they tell you this new device will cause X or do Y, this medicine will help with Z, and you're always a little skeptical. And so, but I had these patients I was now seeing as a menopausal practitioner, and they were coming back and they're like, your medicine's not working, Dr. Leach. I'm still having a problem. And I'm like, you're getting standard of care, you're getting the best we got. And they were like, it's still not good enough. And I'm like, I don't know how to fix that problem. And so, and I had one patient very early on who had pain, was using dilators, was using them as much as she could, and she was not getting better. And I thought, you need to have surgery. So sometimes you just need to take this and make this. And it can be done surgically by a surgeon who specializes in pelvic reconstructive surgery. And so I sent her to Stanford because we don't have one here in our local community. And the Stanford doctor said, larger dilators, longer dilators, more estrogen. I was like, really? That's like the Stanford expert that's telling me that this is the best they've got? And so at around the same time, I heard about this Mona Lisa Touch, which is a fractional CO2 laser. And I said to this patient, call Stanford. One of the studies was done there. Maybe they're still open with their trial because maybe this could help where we were not helping you. Turned out the trial was closed, and she could not enroll. But I looked at the science behind this, which had been in Europe for about 3 years before it was introduced here, came out of Milan, Italy, and it had very good, just like you saw in my previous colleague's slide, very robust scientific safety, efficacy, outcome. You're like, wow, this is the real deal. And I kind of liken it the first time that somebody said, what do you mean we have this thing called penicillin? That was kind of this aha moment, like, what do you mean we have this laser now that we can use, in a woman's vagina to restore tissue health? And so I looked at the studies and looked at the science, looked at the efficacy, and said, okay, I'm all in. And so I bought this laser, and I've been offering it since 2015. And I don't do something as simple and easy that helps with so much and so elegantly than does this laser. For a couple of reasons. One, it takes a minute to deliver the energy. It takes 3 treatments over 6 weeks apart. And you'll see here in the slide the outcome of reduced pain, burning, discomfort, urinary tract infections, improved intimacy, and it's just a light-based treatment. And the other thing that I really sort of didn't know until I had a treatment to offer patients, different than the hormones, is that when I gave patients their hormones, I thought, hey, good for me, lucky for you, we've actually found a solution to your problem. And they would come back and go, I hated putting that medicine in. It reminded me I had this problem, so thank you, Dr. Leach. And I didn't really appreciate that even though the patients were getting standard of care, that the fact they were getting some relief was not really the relief they were looking for, because it reminded them about a problem that they just didn't, that problem didn't exist previously. So anyway, so having a treatment option that now said come back once a year and you don't have to do anything became even more simple and elegant. So again, there's no downtime, no discomfort. You can't have sex for 1 week, but there's oftentimes women who are not having sex at all. So trying to help them begin that again is also how this laser can help restore their intimate health. So this is a demonstration that just shows you the little procedure. There's music in the background, but you don't even hear the music because it's really just the text that you'll sort of see here. I'll kind of talk over it here. So again, it's a little video demonstration here. This little probe goes inside of the vagina. This is just a little guide right here. The laser is delivered off of a mirror, so it doesn't actually touch the cervix. So the light energy is fired off of a mirror here, and it fires sideways into the epithelium here. Now the physics have been worked out. The amount of energy that you use, the dwell time, which is how long the energy is actually delivered to the tissues, And the spacing between the two little laser dots you'll see here is what's been determined to then restore these tissues back to normal. Because if I use lasers to ablate tissue, this is not ablating, we're not burning, we are restoring tissue function. This is what it looks like inside the vagina here, where this little light sort of is being delivered to the side walls of the epithelium. And then there's also a probe that I can deliver the energy on the surface, because as I told you before, the vulva is just as sensitive to this loss of estrogen. These are little zaps, little laser dots, but there's healthy tissue all in between these little zaps here. So you'll see here, this little zap, it vaporizes a little column of tissue. This feels like a little vibration. But there's healthy tissues that are in between these little zaps. And there's little cells called heat shock proteins that are stimulated that says, hey, something happened. We got to go in and fix our little neighbor here. And so it's actually the repair process. So it's a very intentionally induced micro injury that induces a repair process, and it's the repair that leads to a restoration of the epithelium. So you get new collagens, you get new blood vessels, you get basically get your vagina back. Which allows you to have more water. So again, you think of that dry sponge on your sink as opposed to a wet sponge. It's sort of soft and can hold water. That's what this laser allows, is for our water content to be held in the epithelium, so you're just more comfortable. And again, I talked about the vessel, so I can actually deliver the energy right in this area right here as well with a different probe. And that's important because when you get this laser, and when the studies were done, it was only done with the vaginal probe, and the outcomes were phenomenal, but there was nobody treating the vulva and the vestibule. And when I was one of the first doctors in the Bay Area to get this, and we started talking with our physicians and colleagues, we all agreed you had to treat the vestibule as well, and we do that. You get better thickening here, you get better blood flow. It also helps with bladder function, so patients are like, I'm sleeping through the night, my husband's getting up still. So this is what it looks like in a normal healthy vagina. This is, again, premenopausal, and this is postmenopausal thin. This is that nice cushion now, even after one treatment here. Again, patients in menopause have lots of urgency, frequency. After 3 treatments, about a 50% reduction in bladder symptoms. And again, these are the outcomes. This is pain over here with intimacy, dryness, burning. Again, about an 80% reduction in symptoms. With, again, a new paradigm that previously didn't exist. And so, so I went ahead and started it back in 2015. Was the only doctor who had it, but I recognized I was not going to be the only doctor that was going to have it. And now I'm happy that about 6 colleagues have this laser in our community here and offer it to their patients. This is, again, the outcome slide here. But one of the things I recognized about a year and a half ago was that not everybody can afford this. This is not covered by insurance. And so for patients who can't afford this, then they should use standard of care treatment. But breast cancer survivors, they don't always have that option. And so about a year ago, I had a patient come in who needed this treatment, and I wanted to deliver this treatment. And when she asked me what this cost, I said nothing. And she was like, this is free? I go, well, it's not free for everybody, but it should be free for you because you deserve to have this. And if you don't have 10 cents, you should be able to have this restorative treatment. And so, and that just started making me thinking about how do we make this available to the cancer community and not even ask for money? And how does that look, or how does that work? And I'm a busy OB/GYN practice. I have to deliver babies, I have office staff, I have surgeries, so I can't become a free clinic. But what I started doing was offering this treatment, the initial 3 treatments for 5 breast cancer survivors a month with the help of the cancer support community. Because I wanted to be fair and transparent for everybody. So I see Kaiser patients, I see patients from the Central Valley, and my patients are no different. So it's really kind of first come, first serve, and the cancer support community graciously helps to be that sort of buffer that says, we will help you, and I have an email list, and it all comes in, so it's very fair. And so they've been a wonderful partner to help me make this available to patients, and I do 5 a month. Now I recognize that over time, that there may be more than 5 a month, which I'm actually looking forward and hopeful, and hope to convince other colleagues in my community to start offering this for free. And if the list gets too long, I do it for half for the breast cancer survivors. So I have patients in my practice said, Dr. Leach, I can afford to pay for this, I'm happy just doing it, and I charge them half. But when you come back once a year, I still have to have you pay for a little bit. So I charge you just half of what it typically costs. So it's not free forever, but it can be free up front for a small number of women. And a lot of patients, I get it, they said, you know, I couldn't have afforded this. I got bills for cancer chemotherapy. I had a patient recently who was a young patient diagnosed with her breast cancer 6 months after she got married, and her BRCA diagnosis 12 months. She said, I was trying to pay for babies. So again, having this option is a wonderful new paradigm that I'm happy to share with you and happy to talk with you later on. Thank you very much.
Okay. Thank you, Tim. We could listen to that a lot more, but I have a couple more people we want to get up here. So Allison Ryan is the newest addition to the Diablo Valley Oncology team. She is a physician's assistant in oncology, and prior to that, she just finished her training at Stanford. Prior to that, she's a registered dietitian and worked in oncology nutrition at California Pacific Medical Center in San Francisco, and then at Stanford. And she's fabulous, and we're so happy to have her as part of our team.
Good morning, everyone. If it's still morning, I don't know. Okay, I'll try to be fast, but as you've seen, there's a lot of stuff to cover, and we're all pretty passionate about what we're talking about. So, what we'll talk about, I have some huge news for you today, that eating healthfully for breast cancer survivorship is easier than you think. You may read lots of headlines, intentionally or unintentionally. You're just reading the news, you're looking at a shopping website, and you see things pop up on here about nutrition. So I would like to, you don't have to get all caught up in all the headlines and clickbait that you may read out there that may or may not be true. So in the brief time we have, we'll focus on practical food information with the most reliable science and evidence behind it that you can use to make your choices. You'll have more information to empower yourselves to make lifestyle changes that will heal and nourish your bodies and dispel some of the myths that you may read about that lead to food fear and wasted time and stress. Just because you've read it on the internet doesn't mean it's true. Hopefully all of you know that. So there's some resources at the end. I would encourage you to look for some of the original data, some of the original information this is based on, so that you can make an informed decision if this is the right information for you and if it's the right choice for you and your body. And so why do we care about nutrition and breast cancer survivorship? About 33% of initial breast cancer diagnoses could have been prevented with a healthy lifestyle. And that's from the American Institute for Cancer Research. So what does that mean? That means that's not true for every breast cancer. 10% are genetically linked, right? Some other large percent have nothing to do with lifestyle. Some we just are idiopathic. We have no idea why. But 33% could have been prevented in the first place by being a healthy body weight, by being physically active every day, by not drinking alcohol, and by breastfeeding. So that's one of the reasons why we care about this one component is the nutrition. So what should we eat as survivors? So it's all about chemicals. And people are like, oh my gosh, I'm trying to avoid chemicals, right? Chemicals are bad. But we're talking about phytochemical, which means plant chemical. So by just saying plant chemical, you can imagine it comes from plants. So really, a plant-based diet is what's recommended for breast cancer survivors, any cancer survivors, for human beings. So vegetables, number one thing we should be eating that we should make an effort to improve if we're not doing it already. What are the best ones to choose from? You want to look for brightly colored or strongly flavored vegetables. That tells you there's some high value of these phytonutrients in that food. They give it pigment, they give it flavor, they give bitterness, all these things that are in our plant foods. So that I won't read every slide off of here, but you can read for yourself while we're going through this, that basically the phytonutrients either are anti-inflammatory, some of them will even modulate hormones in the body, including estrogen. They have antioxidant properties, they have detoxification. So again, we're not going to repeat it every time, but those are why these nutrients are beneficial for our body. I'll kind of highlight here the cruciferous vegetables are particularly beneficial. So that's broccoli, cauliflower, cabbage, kale, kohlrabi, even arugula. So there's a whole bunch in this family. So some of the resources say try to eat those foods 5 days per week. In an average day, you should try to eat somewhere between 3 to 5 servings of vegetables or even more. So what's a serving of vegetables? Because then that gets confusing for people. I brought my cup up so I could use it as a prop. If it's chopped up vegetables, half of a cup is a serving. So it's easier than you think to get those 5 servings a day or whatever. If it's a leafy green like lettuce, a whole cup is a serving. So keep that in mind, and that it's pretty easy to get a half a cup of broccoli in, or even a whole cup of broccoli, or if you're like me and you're weird, I like multiple cups of broccoli. So, and beyond the cruciferous vegetables, the red and orange vegetables like carrots, bell peppers, and some of the other fruits that have the orange and red, and then mushrooms also have a very strong effect on our immune system. So then fruits. So again, and just that I'm highlighting some, that by no means means that the other vegetables are not good. It's like every vegetable and every fruit has some sort of beneficial component. Some are just a lot more bang for your buck. So we're just highlighting some of those. So fruits are just like vegetables in that they contain some of these phytonutrients, these phytochemicals. So again, look for really darkly pigmented ones. Strive for about 2 servings per day. So again, a serving varies. Fruits have a lot of different shapes, and we don't necessarily chop them all up, but if you chopped it, it would be again a 1/2 cup serving. Or some of them are greater, like melon, it has a lot more water to it, so a cup of melon is a serving. So you want to try for 2 cups a day. One of the things I will point out is fruits, are one of those things when you're trying to watch your weight that can add up kind of quickly. If you're making like smoothies and if you're eating then multiple fruit snacks and having some trail mix with dried fruit, as great and healthy as fruits are, if you're trying to watch your weight and cut back, they're one of the things that sometimes people can get led astray by overeating and thinking it's healthy, but even good food, you can overeat calorie-wise. So just keep that in mind. 2 is the magic number for fruits to get the benefits you need without the extra calories. Herbs and spices, I think, get ignored a lot, but they imagine that powerful, concentrated flavor in just a teaspoon or tablespoon of something. When that amount can flavor a whole dish, that tells you that is very rich in these phytonutrients that are giving it the flavor. So lots of herbs and spices. Probably the most popular one right now is turmeric or curcumin. Let's see, so minimally processed grains. So grains in and of themselves have benefit, but the way most Americans eat grains has less benefit because we do a lot of the refining to them. And the bran and the outer portion of the grain is where really all the nutritional benefit is. And the inside of the grain, for example, white rice, is only starch or carbohydrate, no vitamins or minerals in just the starch. So eat the whole grain version, eat brown rice, eat black rice, eat red rice, eat quinoa, in the whole natural form. And even like a whole grain flour has been processed. So it's much better to boil wheat berries and eat wheat berries than to have whole wheat flour. There's more of the benefit and less of what's called glycemic index or glycemic load. Dried beans and legumes, I also feel like are an underappreciated food out there. Super high in protein, super high in fiber, cheap, right? Dried beans are so cheap. They do require a little bit of effort to cook and prepare, but they're another source of phytonutrients in the diet. And when we're trying to eat what's called a plant-based diet, and you're like, how do I get protein while I'm cutting back on some of the animal foods? Beans are a really great way. And then healthy fats. So we want to eat healthy fats in our diet. Some of the best choices, avocado, olive oil, nuts and seeds, flax seeds, hemp seeds. Some of the like omega-3 fats in like fish. There was one thing, so of course breast cancer is complicated, right? There's all the hormone receptor status, the HER2 status, the stage, all that. Some of the studies, as much as I said this is simple and basic nutrition information, some of it gets complicated when the researchers try to figure out who seems to have the greatest benefit from all the different lifestyle changes. So a big study called the WINS study, they found that a very, very low-fat diet didn't seem to help breast cancer survivors in general, because they were looking like, what are things people can do? So they put people on these very restrictive low-fat diets. So for the general population of breast cancer survivors, it did not seem to make a difference. But when they broke it down by different breast cancer types, they found that the estrogen receptor negative group did seem to have a benefit from particularly restricting fat in the diet. So if that is you, it's something to maybe think about, or maybe go look at that WINS study and look for that information. And again, read and decide if that's something that you could integrate into your life if you think it's right for you. So I point out meats and lean proteins, and specifically unprocessed, because processed meats like hot dogs, deli meats, smoked meats, barbecued meats, those have some carcinogens as part of the processing of the meat. So fresh meat or frozen fish or things like that are the best choices in the meat category. So I've included, again, some of the best choices there for you to think about. But I'm trying to get through these quick because I know we're really over on time, sorry. Coffee and tea is another place where there's benefit in the foods. So I hope you all enjoyed some of the green tea or the chamomile tea, and even enjoyed a cup of coffee. Just try to put as little amount of sugar in it as possible, because the coffee bean itself is another plant, and that has many beneficial effects, and they've studied actually coffee quite extensively, and all the data, fortunately, has pointed toward benefit over any negative, but they were not studying frappuccinos, they were studying real coffee. I also like, this will kind of lead into one of the future slides, but I encourage women that are trying to cut back on alcohol to maybe make a little like tea ceremony session type of thing, because tea can be like fun to like make it a little event. You know, where you have a cool teapot, you go and smell the leaves, and if you're trying again to cut back, this is a really nice, special seeming thing that you can do if you make yourself a really nice cup of tea, if you like tea. And then if you don't like tea, you probably haven't tasted good enough tea. So unsweetened dairy and alternatives. This is another one that's controversial. Some of the like big, like mainstream sites out there will kind of like, there's a book called The China Study, which isn't actually a study, but there's lots of misinformation out there about dairy and dairy alternatives. So we'll kind of spend a little time here. Because, and aside from the China study, there's a lot of soy controversy. People still come and ask me about whether or not soy is safe during breast cancer survivorship. And there's been a very large amount of data and studies done that say that soy is not only neutral, which means will not increase the risk of breast cancer, but may even be beneficial for both preventing it from occurring in the first place and for survivors. So I would encourage you all to not be afraid of looking for, you know, soy as the 20th ingredient in a food and worrying about that. But that being said, hopefully you're not eating things that have 20 ingredients in them. You're eating things that are a little more close to the way they were found on when they grew from the earth. So what are the best soy choices though is like unsweetened soy milk, real tofu, tempeh, soy nuts, edamame, that kind of thing. Because there's been soy protein isolates and things like that added to a lot of foods, which is not what the studies have been done on, or like soy protein powders and things like that. Those are not where they've done the research, so we don't really know that those foods are safe, and they're highly processed. So you want to go with the more, you know, natural form of it. And then plain yogurts, organic milk, hard cheeses actually have, again, there's no association between breast cancer risk recurrence in those foods. So limiting added sugars though, sugar is something that we don't really need in our diet, right? Sugar is completely for pleasure and for taste, and sugar adds a lot of calories. So I don't really tell people that sugar feeds cancer, because it's not that simple and straightforward. But that being said, we should all be trying to minimize the amount of added sugar in our diet. So there's some tips listed here about how to, you know, make better choices. And just as an illustration, you're supposed to try to strive for less than 25 grams of sugar a day, of added sugar. And that's about 6 teaspoons of sugar. But most people aren't, you know, some people add a lot of sugar to like drinks, and you think about that, but there's a lot of hidden sugars, like how much is added to the fruit flavored yogurt that you're having, how much is in that cookie, how much is in the bread, how much is in the ketchup, how much is in the salad dressing. So it sneaks in many different places. So kind of be a little, fortunately there's new labeling that's going to distinguish regular sugar in food, naturally occurring, because like milk has natural sugar, from added sugars. So look out on food labels, as much as they're confusing. One of the new things coming out is pointing out added sugars. So that's really a good change that's happening in the food label, so you can distinguish naturally occurring from added. So as fewer added sugars as you can. And so for like, what's the big picture? What does this look like? 2/3 or more of your diet should come from plant foods, minimally processed plant foods, and 1/3 or less should come from animal protein. So this, in the simpler terms, you know, is basically keep 1/3 of your plate there. That's showing chicken. I guess I can use the pointer if I can remember which button. Which one was it? The little line. Aha. So this is chicken or fish, or maybe it's eggs, or maybe it's even, if it's maybe a breakfast meal, this is yogurt. And then half of this plate is covered in vegetables, and then, maybe another quarter of the plate or so is with whole grain. So this is a really easy way to illustrate how we should be eating. So equally as important as nutrition is exercise, because there really is no other thing we can do for our body that will lower the risk of weight gain and obesity, reduce blood pressure, reduce the risk of diabetes, keep your bones stronger, reduce the risk of Alzheimer's. All these things happen from physical activity, and there's no pill that does that, not even broccoli can do that. So the recommendation is 150 minutes per week of moderate to vigorous physical activity. I would encourage you to try to make it fun, that way it's sustainable and that it seems exciting. I would encourage you to check out one of the free classes at the Cancer Support Community as a way to try one of these new types of physical activity that you've maybe been curious about. Do exercise with a friend. Get a workout buddy or a walking buddy or a dog or something. And then, again, try something new that you've always been thinking about. So what about the other stuff? So alcohol. We talk a lot about this at work because Dr. Saban and I both like our wine. And we're like, well, what can we get away with, So alcohol is a really complicated one, and that we live in this area, near wine country and everything. So the data from a big trial called the LACE study, which was a Kaiser Northern California group, they found that less than 3 drinks per week was a safe amount of alcohol intake, and that more than 3 drinks per week was associated with a dose-dependent increased risk of recurrence. They found that the association was really strongest with postmenopausal women that tended to be more overweight. So again, this is when it gets a little more nuanced of like, how does this information apply to me, and how do I need to change my lifestyle based on it? This can be hard for some people, right? Some people say, I drink 2 glasses of wine a night, and that's something I really enjoy. How do I use this information? Just like the exercise, just like the nutrition, is same for the alcohol. Whatever level you're at, any improvement toward the goal brings benefit. It's not all or nothing. You don't have to be perfect where you're having less than 3 drinks per week, but if you reduce from 14 drinks a week to 7 drinks per week, you're going to get benefit from that. Similarly, if you do 10 minutes of exercise a week and you get up to 60 minutes of exercise a week, that gives you benefit even if you haven't met the goal. So for all of these things, small changes will, improve your health. A little bit more on the meats is to limit the intake. It says avoid processed meats and limit intake of red meat to less than 18 ounces of cooked weight per week. That's a lot. The palm of your hand is about 3 ounces of cooked weight. Obviously, people's palms are different sizes, but it's about 3 ounces. So think about that. So it's actually a pretty generous red meat recommendation. I like to tell people, imagine you were the child and you're trying to teach a child good eating behaviors. Try to control yourself as if you were telling a child how much candy or cookie or cake or whatever they could have. And I also like to encourage people that there are plenty of people that are thin or like a normal BMI body weight, right, but still have cancer. And there's the whole group of people that it has nothing to do with lifestyle. But there is the thin people that have breast cancer that may not have healthy behavior, and that may still have been a risk factor for them even though they weren't overweight. And similarly, there are plenty of overweight women who eat really healthfully and who have a very healthy exercise lifestyle, and they are giving benefit even if their BMI isn't perfect. So I want to encourage people that just body weight is not what matters, it's behavior. So you may never get to a perfect BMI, but if you're doing the exercise and you're eating healthfully and you're not smoking and you're watching your alcohol, all of that, you can be equally, if not healthier, than a person with a perfect BMI. So I want to, again, it's not all about body weight. And so when you think of all these specific recommendations, I like to always remind people to focus on the big picture. People get, again, in a lot of the fears, and I've had women cry to me when they said they dreamt about eating a cookie and they were worried that that would make their cancer come back by just dreaming of eating a cookie. And it's really sad. People get very, very scared, about stuff they read on the internet that, again, maybe not true. So if you eat this one cookie, it is not going to cancel out the benefit of all these healthful foods here. And similarly, if you drink this one green juice, it's not going to make it. So really try to tip the scales towards this end. And also, treat yourself a little bit, like if you were a child. And then if you wanted to learn more about how to eat healthfully for breast cancer survivorship, here are some of the really great websites and some of the studies that we mentioned. These were the biggest breast cancer and nutrition-related studies that are out there, at least now. American Cancer Society has one currently going, but on cancer in general. But hopefully whatever information they come out will be helpful for women too. And that's it. Thank you.
That was so great. Thank you. And I think we will find a way to put slides on the website. So I know. Oh. Okay. Yeah, we'll have it on. Yeah, we'll be able to email slides out and put the videotape on the website. And I know we're a little bit over time. We did get an extension in the room till 12:30. So if you don't have to leave, we'd love to have you stay. We have one more fantastic speaker about to come up here. So I love my job. And one of the things I love most about my job, it may be the thing I love most about my job, is that I spend my days surrounded by heroes. And Allie Jacobs is one of my patients. And she faced her breast cancer journey with courage and humility and humor. And so she's going to come up here and share her journey with you.
Hello. All right. So yes, I did have a unique way of dealing with my journey. Pretty much the only way I could figure out how to deal with such a tragic thing. So when I came to speak here, Sandy said, keep it upbeat, keep it humorous. And it's not a very funny topic to talk about at all, but I'm going to try to make you laugh a little bit. A little background on me. I was a police officer at UC Berkeley for 13 years. I got injured on the job and medically retired. I went on to get my master's degree. My intention was to become a college professor teaching criminology. But life threw me a little bit of a wrench. At 39 years old, I found out that I had breast cancer after I found a lump in my right breast. I went in for my first diagnostic with my general doctor, who said, "You're too young." And I told her, I could feel it, it hurts. Oh, well, that's fine, pain is not associated with breast cancer. How many of you heard that? Right, and you're too young, but we'll order a mammogram. So I went in for my mammogram, which they were in no rush to give me because I was too young. The mammogram was negative because I had dense breasts. They said I had the option to pay for an ultrasound because my insurance wouldn't cover it. And I said, "Can you feel this? It's like the size of an olive. I'll pay it." So whatever it costs, I'm glad I paid for it because they found two masses. I saw a look on the radiologist's face as she was examining my breast. And I knew. Then they ordered an MRI and they found a third mass. So just every test got worse and worse, right? It's just like, what's gonna happen now? So the pictures up here, I look really freaking different, don't I? Yeah. I call this chemo hair. Oh. Yeah, what? Yeah. So I go to Napa on the anniversary of being cancer-free on my birthday, which is in October. What happened in Napa this October was it was on fire. So I didn't make it up there for that follow-up picture, but it's a tradition that I like to do. I couldn't have gotten through any of my treatment without my family, friends, and my partner, who's in this picture. We were together 1 year when I was diagnosed, and boy, did she sure as hell step up. Was there for me every day, moved in to take care of me. And I couldn't have done anything without her support. But I was scared when I was diagnosed. But I saw this slide and I wanted to include it. Fear has two meanings: forget everything and run, or face everything and rise. The choice is yours. So I chose to rise. 2 weeks into the chemo, I had AC. I actually had prescribed 16 rounds of chemo. I got through 13 of them. I had AC, which is also known as the Red Devil, and Taxol. She threw a grenade in my body and it exploded, basically. Thank you. So this is when my hair started to, feel like straw. My kids' biggest concern, I have 2 boys, ages 14 and 12. Their biggest concern was their mom losing their hair. Mine too. It wasn't dying, it was losing my hair. I don't know why we're so superficial when it comes to hair, but we are. Anyway, I told my kids, well, we're going to shave my hair. And they're like, no. I said, well, now you're going to shave my hair, which they had a complete blast doing. I should mention that my best friend is a photographer, and I had her document my entire journey from beginning to end. She is here in this room, but not as my best friend and supporter. She's in this room because she is too battling breast cancer. So she took these pictures and she captured a lot of moments, because while everyone was laughing, there were times that I was crying. But then there were times that I just had to suck it up and move on, right? You cry a little and then you move on. That's how I dealt with my journey, or get back to laughing. Didn't want my kids to see me obviously crying, so I tried not to, but Brandy, my friend, captured those moments very slyly on camera. This was in the chemo chair. I would bring my rainbow unicorn because I had to remind myself that life was all about rainbows and unicorns. I took that thing everywhere with me. I still have it. I still look at it every day. My sister came to spend some time with me while I was going through chemo, and people really do give you the most tough drinks when you're fighting chemo. No offense, Allison, but oh my God, those green drinks that people put in your body. You're already feeling nauseous. It's just like, okay, I'll drink it. But you know what I really like to do after chemo? And look away, doctor, because I would go and have a glass of wine. I may not have felt good, but the wine made me feel really good. So anyway, why I'm here is because I had a unique way of dealing with everything that I was going through, and I called it my Nailed It series. I continued to be an art teacher at my kids' school, and I didn't want the kids to be scared of, bald Miss Allie, so I had fun with it, and I did, wacky things, and everyone laughed, and I figured that, laughter's the best medicine. So I would do these little Nailed It series and post them on Facebook. And it wasn't so people could say, oh, you rock, and oh, you're so, all that sappy stuff that everyone tells you. It was so that they could laugh with me. And when they gave me the free wig, there's a story behind this. So I'm like, oh, free wig, I'll get a free wig. And you go in there and they're like, send us a picture of what your hair used to look like. So they gave me that, and I was like, oh yeah, I nailed it. I only wore that wig once because it was uncomfortable on my bald head. I just embraced being bald. It was just too itchy for me to wear scarves or anything. So I had to do this picture, and then that wig went to another person. Yes. This is before the eyebrow loss, of course. The eyebrow loss, you'll see, caused other issues. But I felt pretty badass that day. So my eyebrows are not gone. I love Doug the Pug. I didn't really know. I don't wear makeup, so I didn't really know how to fix the eyebrow loss thing. So I took photos making fun of my eyebrow loss. Here's where I'm starting to get puffy, thanks to the steroids. I'm starting to feel a little bit bloated. That was the other thing when I was told I had cancer. I don't know if any of you thought this, because I was like, oh, well, I could stand to use a few pounds. And Dr. Swan said, oh, people gain weight with cancer. Like, a bad word. I'm like, thanks, Doc. You're bringing me up here. So now I've discovered the use of makeup to replicate my eyebrows. So I had fun with being the merciless, and now here's where I'm starting to get really, really steroid rage here with the red face and puffiness. And I gained about 30 pounds with chemotherapy, and I'm still battling that. But I did have days where I just felt really bloated, and I just had to embrace that. That said, I would really mess with my kids when I picked them up from school. And there was this internet star called Miranda Sings. You probably don't know who it is, but my son really followed her on YouTube. And I dressed up as her. And yes, and I picked him up from school, and I think I sang an Adele song on a microphone. And I got everyone to look at me and everyone to laugh at me and with me. Get it over with, because I didn't like the stares. I didn't like the pity looks. I didn't like any of that stuff. Let's just have a good time with it. Through all this time, I tried to stay as active as I could. I love stand-up paddling. We used to do stand-up paddle yoga. There were times where I just didn't have the energy, and so I just wouldn't do it. My kids really loved it when I would forget to put my eyebrows on, and they would remind me, like, Mom, I think you forgot something. So it's, the whole makeup thing was new to me, and getting the eyebrows in the right shape, and it's really hard to do them both the exact same. So, I worked it out as best I could. Now, I laughed a lot through my journey, but, I had my moments where I just didn't feel good. And we all know those moments, and it's okay to have those moments where you just don't feel good. But you gotta pick yourself up, and you gotta move on, because that day where you get to ring that bell, and I broke your bell, just so you know. I broke it off the wall. I ripped it off the wall. And I told them I was going to rip it off the wall. And I did. That's my oncology nurse, Anne, who I adore. I didn't stop messing around even when I started having surgery. So I had chemo before surgery. I don't know why, it was just the plan. So I had my surgery, and I continued with my nail that. Because you're really nervous waiting in that room, right? And it takes forever, so you've got nothing else to do, so might as well look like the Statue of Liberty. This was after my double mastectomy that I opted to have in the hospital room. I'm not gonna lie, it wasn't fun. My parents were there. This photo was taken after my mother mistakenly hugged me and bumped my chest. She's a doll. And I was, upset, and I looked at my dad, and I'm like, get her out. I had my surgery the day before Halloween 2 years ago. No, 1 year ago. I was in this seat 1 year ago, 2 days prior to my surgery. So, yes, okay, it's all coming back to me now. I had fun with my drains. Drains suck, not gonna lie. They swing around, you don't know what to do with them in the shower. You're like, what do I do with this thing? You get creative. The day I found out that I was cancer-free, my general surgeon called me and said, did I forget to call you and tell you your pathology was negative? I'm like, yeah, you did. So I was very happy, saved that bottle for a special occasion, and that sure was. This was another great photo that my friend Brandy took after my surgery. We call them naked photos, just to document everything, all my scars and stuff, because I want to be able to look back on that as my journey, my battle, my badge of courage. Just for your purposes, I cropped out good stuff. So this is in the plastic surgeon's office, and what do you do when you're waiting? But you play with the boobs. Well, I do. You hold up different sizes, and you text your mom, and you say, which looks best? The other picture is me getting filled with my expanders, which I hated more than life itself, but I was happy to get them out. I continued on with the Nailed It series once my hair started growing back. I think I look pretty badass in this photo. And then, of course, Sigourney Weaver and Aliens. I didn't really have a proper alien, but that's close enough. And this next photo was taken, I think, a couple weeks after my surgery, where I was told, don't do any physical activity. Sorry, Doc. I had to do a one-arm push-up just to show how badass I was. Then my hair started rapidly growing out. at a rapid pace. In fact, my leg hair was like razor blades as it, like everything is just so alive once the chemo's out of your system. This was one of my favorites. Yeah, and then this was me in the morning. Every morning I wake up looking like Heat Miser, but not to be outdone. Before I discovered the appropriate curl shampoo called Diva Curl, just in case you're wondering. My frizzy hair, I embrace that too. I had fun. I did have fun. Then I got blessed with this, nice hair. I mean, I'm not gonna straighten it anymore. I'm just gonna, deal with it. So, this was my way of dealing with a very hard time. And I'm so glad that I got you guys laughing for a good 2 minutes, because, laughter is the best medicine. And you can feel like crap sometimes, but not all the time. And you can't do certain things sometime, but not all the time. So there were days I couldn't walk to the mailbox, but there were days that I could. So just try to stay positive and focus on what you can do versus what you can't do, and just keep in mind that everything's temporary. All this is temporary. Anything you're going through, any pain, is temporary. And there's a light at the end of the tunnel, and you're not alone. Look at it around in this room. We're all in this together. Thank you very much.